In this video, we shall examine the chronic pain that some patients suffer after the repair of a groin hernia. We shall look at the causes, how best to investigate it, and its treatment. Let's look at this cartoon. These are the three common sites of hernia in the abdomen, around the belly button, and in the groin. A hernia is a defect in the abdominal wall, allowing the contents of the abdomen to come through as a pouch, as shown over here. So what is chronic pain? Firstly, it's important to differentiate it from normal post-operative or post-surgical pain, which may last for a few weeks, initially worse in the first 3 to 5 days and then gradually improves. In general, the great majority of the patients will go back to their normal activities in about 4 weeks. However, if the pain or any component of it lasts longer than 6 months and it interferes with their activities of daily living, such as driving, walking, exercising, sexual activity, then that is termed as chronic pain. How common is it? Around 1 to 3% of the patients have been reported to suffer with chronic pain after a groin hernia repair. Hence, 97 to 97%, the great majority of the patients do well, but because the hernia is such a common condition and these operations are performed at such a huge volume, that even this represents quite a high number in the population. Which patients are most at risk of getting this kind of chronic pain? Younger patients, female, those with significant pre-existing pain, and specifically those where the sudden severe pain starts right after the operation, as soon as they wake up. Now, what are the issues that do not have an impact on chronic pain? And these are usually discussed in the literature. Mesh versus no mesh has no long-term consequences, whether a mesh is used or not. The type of the mesh after 6 months has no bearing on outcome or chronic pain. And the way the hernia is repaired, whether keyhole or open approach, again, has no bearing. Chronic pain is also a less likely feature of laparoscopic repair. Some studies have suggested a slight benefit for the laparoscopic repair. The cause of chronic pain, firstly, nerve injury. In the cartoon over here, this is the front, and this is the left groin, which has been opened up prior to hernia repair. And the yellow threads are superficial nerves that run through the groin, and these have to be safeguarded. Otherwise, patients are at risk of getting chronic pain if these get tied in a suture or get caught up in inflammation. Once the hernia is repaired, with a mesh or without, tissue inflammation may occur, causing chronic pain. A stitch is placed near the pubic bone over here, and sometimes if it's too deep, it may cause inflammation of the pubic bone called periostitis. Scar tissue may form over time at the site of hernia repair or where the mesh has been placed. Rarely, infections may arise. The hernia may actually recur, giving rise to chronic pain. The mesh placed may actually get displaced, or it may roll up, or it may form a little bundle, which was not the initial intention. Connected to it is a condition called a meshoma, where a mesh forms a little ball and then may press upon the adjacent tissues or cause inflammation. Rarely, there may be serious injury to the spermatic cord or to the bowel or urethra, giving rise to chronic pain. Now, it is also important to differentiate pre-existing pain for whatever cause, which may continue after a groin hernia repair, and this has to be investigated in its own right. And it is also very possible that new pain may arise in the groin, sometimes months later, which may have no relation to the hernia, and this may be related to the muscle, the tendons, the hip joint, the back, or causes in the abdomen. There are 4 different types of pain typically that patients suffer. Of course, they overlap, but it's important to understand the basic features and what are the underlying causes. The first and the commonest is the nerve pain called neuropathic pain. And just going back to this example over here and the 3 nerves that I outlined just to show how these can be implicated, you can see a suture that has accidentally been put across a nerve over here and over here. That can sometimes happen, or a part of the mesh may become inflamed or be caught up in inflammation, giving rise to irritation of the underlying nerve. So what kind of pain does it produce? It is sharp stabbing, throbbing, and shooting or pricking pain. Typically, patients may say that they are being stabbed, It radiates down to the scrotum, or in women down. Patients may have loss of sensation in the area that the nerve supplies, and that is very typical. Doctors can pick it up about which particular nerve is injured, or the sensation may be heightened or altered. This pain is worse on movement, and tapping at certain trigger points elicits a sudden pain, a bit like an electric shock, and that is called Tinel's sign. And finally, this pain improves when patients lie down, they flex their hip or their thigh. The second variety of the pain is the somatic pain. In this type, in the groin hernia repair, in this region, the pubic bone, a stitch is accidentally placed too deep, causing inflammation of the underlying bone called periostitis. This type of pain is very localized. This area is tender and it remains tender to touch, representing this area on the human body. The third kind of pain is called nociceptive. This is due to infection or inflammation. This pain is deep, dull, constant, gnawing, aching. It is localized over the entire groin or maybe over the whole of the area of the mesh. And to separate it from the neuropathic pain, there are no specific trigger points or tender points for this particular type of pain. And lastly is the visceral pain. This is due to injury to the bowel, the spermatic cord, or to the urethra that carries urine from the bladder. This is the least common, and it may manifest itself with sexual dysfunction, pain during ejaculation, or superficial tenderness in the area, or gastrointestinal complaints such as abdominal pain or functions of the bowel. In terms of diagnosing the cause of the chronic pain, it is really important that the clinician chosen have an interest in chronic pain after groin hernia repair and that they have experience. The patients ought to be examined very thoroughly by taking a detailed history, including the operation notes, and examining the patient carefully, including the check on these nerves as laid out over here, the 3 nerves, but there are other nerves that can be implicated in the groin, mapping out the loss of sensation or altered sensation on the body and matching that to the nerve. This may well include examination of the hip, the back, the groin for musculoskeletal disorders. Once a thorough history and examination has been completed, other investigations may be required, such as dynamic ultrasound scan to assess for recurrence, inflammation, infection, mesh migration, or CT scan. The most favored one is MRI scan of the groin because it will not only tell you about issues related to the mesh, as well as pointing out other problems in the groin and the hip area. And sometimes nerve studies are required to understand the implication of nerves in the chronic pain that the patients suffer. In terms of treatment, it is really important to try and find the cause of the chronic pain and treat the cause, and to have an open mind about other causes in the groin that may give rise to chronic pain and not just the hernia repair. This is best done by teams or clinicians who have a professed interest in groin hernia repair and specifically in chronic pain associated with hernia repair. So firstly, the great majority of the patients will improve over time, although the pain may not have settled over 6 months, but if given time, the intensity of the pain reduces enough for them to allow near enough normal life. Patients may try simple painkillers such as paracetamol or other non-inflammatory medication if appropriate. The one drug that has shown benefit is the gamma aminobutyric acid. This is best done under the guidance of a specialist. There are other medications which may be of help, and yet again, these are best deployed by a specialist team, including pain specialists. And these medications may include opioids, use of amitriptyline, cannabinoids, other medication. Alternative treatments such as acupuncture can sometimes be helpful. Patients with chronic pain are best seen by chronic pain specialists with a professed interest in the groin, and what they may try is to rule out nerve injury as a cause of pain by injecting each particular nerve and seeing whether a local anesthetic injection gets rid of the pain, and this may be an avenue to long-lasting pain relief. Neuromodulation in selected patients of the back or specifically of the nerves by means of specific devices has been helpful for some. And finally, if a particular nerve has been identified as the source of pain, then that nerve may be destroyed by giving ablative chemicals using ultrasound guidance. It is also important to remember that by destroying nerves that are working, that parts of the skin may lose sensation, and equally, if the nerve is destroyed that supplies a muscle, this may cause problems with how the abdominal wall may react, and there may be an unsightly bulge. So these treatments are not without some degree of risk. Lastly, and most importantly, is surgery for chronic pain, and hence the diagnostic process would have highlighted patients who would most benefit from surgery, specifically those who have a recurrence of the hernia after the initial repair, or if the mesh is displaced, or the mesh is malformed, or the mesh is infected. In these patients, surgery would be most beneficial. Surgery has its own risks, which include damage to the surrounding structures and the risk of losing a testicle for men, as well as a high risk of areas of the skin that may lose nerve supply due to nerve damage. As seen in the picture, these 3 nerves, or all of them, may get damaged, which may be unintentional. However, it is important also to highlight that surgery may be most beneficial when it has a direct role. There is a specific operation which gets rid of all 3 nerves which supply the skin around the groin area and are a source of pain, as well as removing the mesh. It's called a triple neurectomy and mesh removal. This means dividing the nerves well away from the operative field and then leaving the cut ends, removing all of the mesh material from this area, from the groin. And patients have reported 85 to 90% success rate with this very radical operation. As highlighted before, this is best carried out by surgeons who are experienced in this and by our team which assesses the patient accurately. This ends this topic. If you have any comments, please